So safety, and Kevin mentioned it earlier today, the whole notion of violence in inpatient settings has been signalled as one of those difficult things that people are trying to cope with in inpatient units, and in their efforts they're worried about how they can reduce seclusion and what is it that they can do differently. So we've pulled together some information from other units where they're having success in reducing violence and increasing safety, and not just safety for consumers, but safety for staff, safety for all. So these are some tips, learnings from other people that you can start applying and testing in your particular DHB acute inpatient. So just thinking about the context, when we first started this work, people did say to us, while you're reducing seclusion, you may well increase staff assaults. And you may have heard that in your particular DHB, this is going to affect assaults on staff. So we've used staff assault and consumer assault as balancing measures. So the balancing measures to ensure that there's no unintended consequence of the improvements that we're making. And you and your project teams are submitting your data for your balancing measures. So remember the 3 balancing measures: personal restraint, the staff assaults, and the third one, can anyone remind me? Medication use. Thank you, Brendan. So when I was talking to David Godire actually about contributing factors, my top bullet point was the psychopathological symptoms. Well, he told me I had them in the wrong order. That more often people become a little bit agitated or annoyed in the acute inpatient unit due to frustration. And sometimes there are just too many people in a close area. My goodness, what are we doing here today? I hope everyone's feeling okay. But that notion of overcrowding and staff attitudes are actually triggers for people feeling uptight, agitated. Limiting freedoms, so things like actually no, you can't go on leave is a trigger. And attempts by staff to set boundaries for apparently no reason. So sometimes we have ideas about what people should be doing, but we've not really conveyed those in necessarily the right way, or they're misinterpreted or misunderstood. So what are some of the ways we can communicate that? And of course we're aware of the alcohol and drug use and the impact that has, and we've heard from people today about that. And then of course our psychopathological symptoms put at the bottom. So a lot has been written about that, and I just want to acknowledge Helen, Emma and Caro from Tapo at the back there, and they've written a lot about seclusion reduction and risks to staff safety. And in a publication in 2014, they said there's no magic bullet. All right, there's no magic bullet to this, but there are a set of choices. And although it was 2014 and we're now 2019, there are still things we can learn. When we've talked to those in the Scottish Safety Programme, yes, they've looked at violence reduction. And when we've talked to the Eastern London Trust, and Kevin Cleary talked about it this morning, yes, they've looked at violence reduction and they've had some success in reducing violence, but a number of things that they've needed to look at. And looking at the slide here, you can see the importance of the environment, the importance of leadership, and of course we had adverse events, and how we respond to adverse events is significant. But there are predictive tools that we can use, and from listening to people today about their driver diagram, some of those tools you're already using. So that's fantastic, isn't it? That you're actually thinking about what is it in your inpatient unit environment that are potential triggers for people becoming upset, and what can you do about that? Many of you are using data to inform what's happening on the unit and where the triggers are, and you're able to review situations where there's been agitation and leading to violence, and think back to, well, what was it? Was it a over-occupancy situation? Was it a staffing situation? What are some of the triggers that led to that? And by having the data, it makes a lot stronger case for doing things differently, rather than you looking to each other and sort of saying, oh, what do you think? Having that supportive data does help your perspectives. I just remembered we had this clicker here that we should be using. So when we talked to Scotland, we said, what did you do to reduce the violence? They said they started welcoming people with a cup of tea and some hot toast. It just seemed too easy. When I think back to the 70s, when I started my nursing training, when people couldn't sleep at night, we were always making a cup of tea and hot toast, and it certainly seemed to calm people down, and they felt a lot more comfortable and didn't worry about not sleeping. There's an initiative called Safe Wards, and I don't know how many of you are familiar with it, but I understand Southern DHB have pursued the Safe Wards. And when I looked at these 10 simple interventions, I thought, my goodness, why aren't we doing these? And I like that one, and that one looks quite good. I was told I can't cherry pick. There are 10 interventions, and the idea is that you implement the 10 because the way that they interact with each other all adds value. So, mentioned Southern DHB, there are acute units in Australia that are using the Safe Wards approach. There are units in the UK that are using it. When I talked to Kevin Cleary about the Safe Wards initiative, he said to me, oh, well, they tried it at East London Trust and it didn't work. So with any of these initiatives, what have we already heard this morning? Take that idea and test it in your own local context. What needs to happen in your own local context? So Kevin showed you some data this morning about the East London Trust, and they have adopted predictive approaches, and one of these is this violence checklist, which is an instrument which can signal to staff about potential violence for individuals within your units. So safety huddles, that's something very popular in the East London Trust. And that safety huddle isn't just about, anyone or the person nominated responsible for safety in the unit. It's bringing everybody together in a safety huddle to say, well, what's happening on the ward? Who's happy? Who's unhappy? Are there particular staff that are feeling out of sorts today? Not just necessarily your consumers or service users. Are there people that have received some bad news? Are there those that their holiday's not working, or there's been some family issue? What are the sorts of situations that you need to be thinking of that might affect people's state of mind? We've heard about the safety cross, and when we first started the Zero Seclusion project, you might have recalled we used some safety crosses like a big S for seclusion for you to colour in the days that people were secluded or not secluded. This is another opportunity to have a visual track of any safety or in this violence-free days is what they're calling it here. Did anyone use the safety cross in your DHB? We've got some hands. My goodness, there's quite a few hands going up for the safety cross. Fantastic. Safety meetings. So, we're very familiar with the health and safety legislation and the health and safety committees that are occurring. But at a local level, safety needs to be signalled as everybody's business, not just one person who's a health and safety rep. And safety meetings involve everyone. And you might think, oh, we've got too many meetings. There's no reason why you can't make safety an agenda item on one of your regular meetings. So if you think back to your driver diagram, And you'll see at the bottom there the PDSA cards, that pocket cards that we've provided. You're welcome to take those away. In your driver diagram, there's an opportunity to signal that violence reduction, or violence is one of your drivers. So looking at reducing violence will help you towards your goal of reducing and eliminating seclusion. So if you've got that in your driver diagram and in the primary drivers, and I can't claim responsibility for this beautiful driver diagram, this is Karen O'Keefe's work. If you look at the primary drivers, reduce violence in the inpatient unit, and then through to the secondary drivers, data transparency, your predictive plans, reviewing your violence incidents for learning, de-escalation areas. So think of all those particular areas that contribute to that reducing violence in the inpatient unit. And we've just been through a whole range of change ideas that you could potentially test that are going to contribute to you reducing violence. So we understand the drivers to violence and agitation in our areas. We understand the change ideas, and many of these are being tested here in your DHB acute units now. The safety cross, the predictive screening, safety huddles, safety planning. So as we move forward to reduce and eliminate seclusion, we expect you as project teams to be out there testing these change ideas. And when you're testing change ideas and adopting, adapting or abandoning to get towards eliminating seclusion, we would expect to see a reduction in violence in your acute inpatient settings. This is what's happened in the East London Trust. This is what's happened in examples in Scotland where they've looked at change ideas to reduce violence. This will improve our acute inpatient settings. They'll be safer for staff, safer for our consumers and family whānau, be safer for all.